evening, everyone. I welcome all of you to another digital symposium by Veiva Scientific in collaboration with Abiomed. We are honored to have all of you here with us this evening as we discuss the ever important topic of managing complex PCI with Impella. Before we begin, I'd like to say it's a privilege to host reputed national and international guests. I would like to extend my gratitude to our esteemed panel of moderator, guest faculty, expert panelists, and speakers for taking out time from their busy schedule and join us here to share their knowledge today. Now, to take us through this evening session, we have the pleasure of having Dr. Rajneesh Kapoor sir from Medanta Medicity Hospital, Gurgaon, as our moderator. Dr. Rajneesh sir is an experienced healthcare leader and a leading authority in interventional and structural cardiology in India for over 3 decades. Thank you, Rajneesh sir, for taking the role of moderator this evening. And we also have eminent doctors from India as well as abroad as our expert panelists and speakers. Once again, thank you everyone for joining us. Without further ado, I now hand over this platform to our moderator. Rajneesh sir, please take it ahead. So you are on mute.
Okay, thank you very much. And so we are absolutely starting this very important session, and which is based on Impella guided PCI. So I think we all know that last few years we have seen a surge with these kind of complex procedures and being supported by Impella. So our data is also accumulating more and more, and with that increasing data, we are getting more and more comfortable to do very complex procedures, which perhaps initially we were not thinking. But with Impella usage, with availability of Impella, I think no doubt that it has expanded our horizon to tackle very critical cases also. So today is one symposia where I think a lot of speakers will be presenting their experiences, how they have managed their complex cases with the support of Impella. And there are still many questions which come to our mind. Which are those specific cases where Impella will be absolutely useful and a savior to salvage such complex cases? And secondly, then once we use Impella, how to take out Impella, how to wean off Impella. So all these cases will be answered with this symposia. So we are absolutely privileged to have a very good faculty for this session. And I'll just name initially our expert panelists. So Dr. Girish is a very versatile cardiologist from Bangalore. Dr. Anantaraman may be joining intermittently from Chennai. Dr. Rahul Gupta is from Mumbai. Dr. Bali is from Mohali. Dr. Anand Rao is from Mumbai again. And again, it's an absolute privilege to introduce our first speaker, Dr. Federico, who hails from Catania, Morgagni. Professor Federico Papaldo is a distinguished expert in anesthesia and intensive care, currently serving as professor at Core University, ENA. And he has, extensive experience with these complex situations, with extensive leadership roles across renowned institutions. His expertise spans mechanical circulatory support, coagulation, and bioengineering. He has numerous publications and original research, and also medical device patents. Welcome, Dr. Federico. Dr. Federico, can you hear us?
Hear me?
Yeah. So we can hear you, Dr. Federico. Everybody is waiting for your expert talk, how to escalate in a shock situation from inotropes to Impella.
Yeah, so good morning, everyone, and thank you for inviting me to this webinar. It's my pleasure always to have interaction with the Indian colleagues. So I know this is going to be mostly focused on protected PCI symposium, but I think that it's very important to recognize that the proximity between protected PCI cardiogenic shock is very close, and we have to learn, as you mentioned, that data are accumulating about the value of this Impella therapy
Dr. Federico, you are on mute. Kindly unmute yourself.
Okay, can you hear me?
Yeah. Now we are able to hear you, sir.
Okay, so what is the contemporary mortality of cardiogenic shock? What is the role of the balloon pump, if any? What is your current approach with temporary mechanical circulatory support to patients who have cardiogenic shock SCAI C, D, and E? What etiology of cardiogenic shock do you face in your clinical practice? And how much, if any, access do you have to organ donation and heart replacement therapies? Because we are now in the era of the danger shock trial. So the previous randomized trials have shown that there is no benefit of using the balloon pump or ECLS in patients with acute coronary syndrome, infarct-related cardiogenic shock, whereas there is a landmark trial in 2024 published in the New England Journal of Medicine showed that there is a significant, statistically significant benefit of using Impella CP in patients who have STEMI complicated by cardiogenic shock. And the paper was very important because it was conducted in a population of more than 300 patients in whom there was a very low rate of crossover, so very I would say univocal data, in which the Impella device was deployed before revascularization in the majority of them, but in whom the duration of support with Impella was median time in hours, 59 hours, and 81% of patients were successfully weaned from the Impella device. However, I want to recall you, as you have asked me to discuss about the role of inotropes and escalation, that in this trial, patients were receiving mechanical support with Impella, yet they received a lot of inotropic agents. 88% of patients receive whatever inotrope you can consider in your clinical practice, but
Dr. Federico, we are not visualizing your slides.
Oh.
Can you share those slides?
I'm sharing. So.
Hi, Nishant, can you please help?
So I want to remind you that the majority of patients still received inotropic therapy. In this slide, you can see that 88% of patients in the Impella CP received any inotrope or vasopressor. And what is most important, that patients were allowed to receive inotropes at the time of weaning from the Impella device. So ultimately, the trial was able to show that there was a significant benefit in terms of survival rates in patients in the study group with a number needed to treat of 8, which means that the mortality was abated from 58 to 45%. And you see here that the benefits in terms of survival increase over time, and these Kaplan-Meier curves continue dividing because probably there was an impact on positive remodeling. However, the trial was also able to show that there is a significant amount of complications which can occur in patients treated with Impella CP, namely bleeding and renal failure, yet these complications did not affect negatively the survival rate and the impact of the therapy in terms of survival benefit. But how to translate this danger shock trial data in our real life daily practice? It's very important to take into consideration that, of course, this should be generalized because it's a randomized trial. But of course, there are many implications in clinical practice that have to be explored and discussed before having the capacity to treat every patient with an Impella CP in this context. We have to remember also that despite this significant impact in terms of survival rate, yet the mortality rate of the general population, if we compare the data to other trials who have been performed in the field of cardiogenic shock related to AMI, is still very high, so extremely high. So I think that we have to start from a couple of facts. First of all, of course, the overall survival rate was in the control population in between 54% and 51%. But if you have no hypoxic brain injury, the survival rate can increase up to 50%. And if you use mechanical support, not as a primary strategy, but just waiting until you need a bailout mechanical support, the mortality rate is going to be 72%, so significantly higher. The second fact is about the discussion on SCAI stages, which have significantly improved our capacity to stratify the severity of patients with cardiogenic shock. But we like to remind that the SCAI stage, which is mostly related to prognostication, is at 24 hours. So that means that we have to be within 24 hours if we want to change the perspective in terms of prognostication of our patients. So our platform has to be from the very beginning very effective, and we do not have to wait for bailout. The other consideration is that still, if in doubt, if you fail your reperfusion, if your lactates are above 5 and your patient is hypotensive, less than 80 millimeters of mercury of systolic blood pressure, this is definitely the patient who will benefit from mechanical support. Of course, there are a lot of things that are
audio is gone.
Hemocompatibility. So bleeding complication, thrombosis complication have a role in determining the complexity of this scenario. And of course, we have to go into the details of this phenomena to understand how much of these complications are impacting on patient prognostication, and if we can apply any strategy to mitigate this effect in terms of antithrombotic strategy or management of the pump and the native heart. And this is a sort of score that we have tried to design. Fourth, it's access to escalation. I mean, not every single patient can be managed by a pump. Probably there are patients who would need a combination of devices, and we will discuss about that later. The second fact is that if we want to have native heart recovery, we have probably to change our approach and exploit the temporary mechanical support platform to be able to take inotropes off the scene and use other agents which are prognosticators in terms of heart failure, such as guideline-directed medical therapy, instead of using inotropes or vasopressors. And last but not least, we know that possibly Impella CP before PCI can limit infarct size, which can, of course, as mentioned, impact mortality, but also promote positive cardiac remodeling, which means having higher left ventricular ejection fraction after revascularization. This mantra about inotropes is I would say, redundant in the literature, because we know that many papers more than 25 years ago have been able to show that inotropes are associated with mortality, and the more the inotropic score, the higher the mortality. We know that the use of any catecholamine, I do not like to discuss whether it's epinephrine or norepinephrine or dobutamine. All catecholamines are associated with mortality, and also in more recent papers which have been published by the Cardiogenic Shock Working Group in the United States, colleagues have been able to show that the number of vasopressors is significantly associated with the probability of mortality. No option for other agents, so forget about levosimendan, which has no value. And don't remember that the value of the platform with mechanical support, especially with the microaxial flow pumps like Impella, is that the system is not necessarily providing increased in cardiac output, but it's providing native heart rest, which means that the amount of ejection or systemic flow which is provided by the Impella pump is able to put the patient at rest. So the native ejection is reduced and the total ejection is increased thanks to this effect, which is, you can draw a line here. Half is unloading and half is augmentation of cardiac output, which of course it's not a figure which can be provided by any other mechanical support available nowadays. And the guidelines from the European Society of Cardiology since 2021 have started to consider the fact that inotropic agents should be used with a class of recommendation 2B versus short-term mechanical support, which is on class of recommendation 2A. So better mechanical support than inotropes. Because I think that in my personal perspective, catecholamines are toxic, the inotropic score is associated with the mortality, and deterioration through the SKY stages is associated with the dose of inotrope, so the inotropic score. And of course, if you use a device, you have to exploit fully the performance of the device, among them not to use inotropes. Rather, you have to control heart rate with beta blockers, which can be administered if a patient is on mechanical support. If you have to increase blood pressure, you can have alternative strategies or agents which can keep blood pressure in the normal range if you have any vasodilatory scenario. And therefore, I strongly advise to perform mechanical support without catecholamines, because if you want to put the heart at rest to unload the left ventricle, you cannot use catecholamines. And of course, when you remove mechanical support, you shouldn't use catecholamines. Otherwise, you are going back to the point where you started from. You know that data have been generated in the recent years, and of course, danger is pivotal and landmark in this regard. But we have also realized that these patients are not the only ones we are facing in clinical practice. So it's not just about STEMI. There are a lot of disorders which can be non-ischemic cardiomyopathy, heart failure, myocarditis, drug intoxication, which appear to our clinical practice. And these patients have different presentations in terms of the place where the patient is identified as being a cardiogenic shock, the kind of tools that we need to identify and stratify the cardiogenic shock, so pulmonary artery catheter or echocardiography or labs, and this might turn into a different platform for temporary mechanical circulatory support. So I think it's very important that we stay on the data that tell us that it's not about acute coronary syndromes. So what is escalation in this regard? It's a lot of things, because I think that, of course, we can consider that the standard of care now, it's Impella CP, and you might be in the need of escalating Impella CP. But I think that there are a lot of preliminary things to be assessed. First of all, the first escalation is the hub and spoke concept. So if you have a cardiogenic shock patient, this patient has to be referred to a hub center. This is the first escalation. Then you have to escalate the patient to inotropes, if they are on inotropes, to temporary mechanical support, which means basically that every patient who is referred to you for cardiogenic shock and is receiving inotropes should be considered for mechanical support. Then you have to also escalate the balloon pump if you still use the balloon pump, and to identify which is the best strategy, because of course could be an Impella CP, but also Impella 5.5. And if you have an Impella 5.5, which needs to be escalated, this would mean escalating to an ECPella, so adding ECMO. Or if you have pure biventricular failure, you might consider adding an Impella RP supporting the right ventricle to a left-sided whatever Impella pump. So basically, it's important that we identify escalation as the process of recognizing first the evolution of biventricular failure, the oxygenation insufficiency, or the insufficient device support. So these are three pictures that we have to first identify before we proceed to escalation, because of course that is associated with different platforms in terms of devices, and you see here that everything is different according to the kind of preliminary pathophysiological background. So what I consider in my clinical practice is that if you still are on inotropes with an Impella CP, consider escalation. The escalation then requires echocardiographic evaluation, and you have to see whether and pulmonary artery catheter, because if just an insufficient support, so isolated left ventricular dysfunction, you can provide an Impella 5.5 by the axillary artery. Whereas if it's biventricular dysfunction, you have to distinguish whether this is primary right ventricular dysfunction in the context of a left ventricular dysfunction, or it's secondary to the fact that the insufficient unloading of the left ventricle is increasing the right ventricular afterload and putting the right ventricle in difficulty. But how can you provide this with an Impella CP? Impella CP has some limitations, as I have shown, because the duration of support in the danger shock was limited to less than 3 days. And of course, if you have an Impella pump in the femoral artery, you can have issues with ambulation, durability, and also hemocompatibility for a long period of support. Therefore, it's very important that you stratify your patient. If you have a patient SCAI C with Impella CP, usually it's not necessary to escalate. But if the patient is going down and it's deteriorating to SCAI D, you have immediately to consider escalation, because the capacity of provide sufficient prognostication is very, very poor. It's very, very poor. In this regard, we currently have large access to Impella 5.5 because of the technological feature of the device provide us a very impactful therapy in terms of hemocompatibility, stability of the position, and durability of the device, besides the amount of flow which is provided. And we have been able to recently produce this paper to show that if you have a native heart recovery after Impella 5.5 for cardiogenic shock in patients who are treated primarily with this strategy, in order to achieve 0 inotropes, administration of guideline-directed medical treatment, prolonged duration of support in terms of duration of Impella pump, you can have 81% of survival rate with only 19% of mortality. And you see here that the majority of patients will have survival and native heart recovery rather than need for heart transplantation or durable LVAD. You see here that if you look at the data in terms of native heart recovery and you follow up these patients, the impact of this therapy on patients who have severe comorbidities, severe vasculopathy. So 30% had no access from the femoral artery, who have cardiogenic shock mostly in the stages D to E, low ejection fraction, preserved right ventricular function as measured by TAPSE. You can see that the inotropic score, which was a mean 23 before therapy, in patients who had coronary artery disease, decompensation of heart failure, arrhythmic storm, and who had full revascularization under Impella support during the assistance, will have a duration in mean of about more than 10 days. Some patients are escalated from the balloon pump when they are quickly on the other side de-escalated from ECMO support, so that the duration of Impella is less than 3 days, and the duration of Impella is more than 10 days, with a low rate of complications, which did not affect patient survival. So 2 mild bleeding, 1 intestinal ischemia without complications, and 1 hemothorax. And you provide them guideline-directed medical therapy. The left ventricular ejection fraction at discharge is 33%. And you see here that at 180 days, 95% of them are alive. Just 1 death because of non-cardiac causes. And the rate, the functional status is in between class 1 and 2 NIH for the vast majority of them. And the mean left ventricular ejection fraction is 35%. And only 6 patients had ejection fraction less than 30%. And you see that the survival rate is very high. We have a coincidence between the rate of Impella removal and survival. If you see danger, 81% of patients had Impella removed, but only 56 survived. So which means that there is still some mortality after Impella removal. The rate of rehospitalization is very low, just 2 cases of rehospitalization for heart failure. And the benefits of this new approach can be performed with a low rate of complications. So I think that at the end, if you want to cancel inotropes, if you want to provide guideline-directed medical therapy, if you want to provide prolonged support, we have to consider that CP should be escalated to Impella 5.5. And we can achieve native heart recovery. We do not have to go straight to transplantation or durable LVAD. But of course, if the patient on CP is in the need for escalation in the early 48 hours, I think that ECMO is still the best option because shock is unresolved. Whereas if you have the need for escalation after 2 days, this means that you have resolved shock, but you have no signs of heart recovery, and you have to provide a more durable support. So at the end, I always use the motto, it's never too early, but it's often too late to escalate. So in conclusion, I think that the role of Impella in cardiogenic shock is expanding. We know that danger is providing us the basis for using a primary Impella CP in patients who have an ischemic etiology, but still a lot of work has to be done to further improve results, because we can also change our ICU management, change our vision in terms of how to provide the best support to our patients with the Impella device. Thanks for your attention.
Well, thanks, Dr. Federico. This was a wonderful analysis, and it was very lucid talk. So I think we can have few questions. I can enroll some of the panelists. Dr. Girish, you want to share?
Yeah, Dr. Rajneesh, I just wanted to ask him, now that you presented this data, what is your cutoff point? When do you use CP and when do you use 5+, when you look at a cardiogenic shock and management?
So that's a good, very good question. So in our clinical practice, we have realized that 60% of patients present at our institution as primary hospital. Sorry. The remaining are transferred. So if a patient is with STEMI in our institution, so goes direct to the cath lab, CP is the first choice, no discussion. But if the patient has been treated in another hospital, which has no facility for primary PCI, or has the facility for primary PCI, but has no mechanical support, then we consider whether to go directly with a 5.5.
Okay. And in your cath lab, if they have presented you for the first time, are there situations where you may use 5.5 as the first choice?
For STEMI,
Yes. No.
very rare, very rare,
Very rare.
very rare.
Got it.
Sometimes it happens that you do the primary PCI without support, then the patient is brought to the CCU, then you realize that there is no improvement, so the patient is in cardiogenic shock, and at that time you can consider a 5.5. But if you are in the cath lab, it's CP.
CP. Thank you.
Yeah.
So I'm just extending this discussion further, Dr. Federico. So mostly you are saying STEMI with shock, you are inserting Impella in the cath lab, right? Prior to angiography?
Not to angiography, prior to PCI.
Prior to PCI. So angiography.
Not to angiography. To
Okay.
angiography is still too much.
Okay. Okay. And any what are the frequency of vascular complications you feel after the Impella insertion?
So we are very, very careful about the vascular access. So in case we have patients that we think we cannot make a safe vascular access, we try to be, let's say, prudent, because we don't want vascular access complications. We don't want it. So rather, we provide a short balloon pump, and then we go to the OR and use a 5.5 via the axillary artery.
Can I ask a question?
Yeah, Rahul, go ahead.
Yeah, so like after a STEMI cardiogenic shock, what is the duration which you typically keep for the Impella? So whether you remove it on the table or you keep it for 24, 48 hours, what is the usual practice?
So for cardiogenic shock, never remove on the table, never. The patient has to be on support and not support the most extended duration of time as possible, which might mean at least 3 days, at least 3 days. Of course, it's prerequisite that we have to be off inotropes. We never remove a pump if the patient is still on inotropes.
Now, when do you decide intra-aortic balloon pump may suffice or Impella is the way to go?
So the intra-aortic balloon pump is restricted to patients who have no vascular access.
I think Girish made it clear. The Sky D is for sure Impella, and Sky C, if it is deteriorating to Sky D, the lactates are deteriorating, and there are some organ system damage failures happening. I think then it's surely an Impella case. I think that.
And I think it's very important that you also bear in mind that failure of revascularization, of course, is a prognosticator. So if you fail to reperfuse the artery and the patient is not doing well, I mean, it's no discussion, because of course that patient will for sure deteriorate. So on the table in the cath lab, you have consistent data to proceed with support.
What I understand after listening to you is putting in any inotrope is actually detrimental. So second, IABP is only when you can't do a CP.
Cannot hear you.
Now, is there any role of inotropes at all in this management of shock? I'm sorry. Can you hear me?
Now, yes.
Yeah. Is there any role for inotropes at all in the management of cardiogenic shock?
For what?
For the shock.
So
cardiogenic shock.
I'll repeat the question what Dr. Girish is trying to ask. So from your presentation, it was getting more clear that, you know, lesser the inotropes, better it is for the patient, right? So, but still, you know, we may have a situation where both inotropes and Impella we require to get the patient out of this vicious cycle. So obviously, you know, I think what I get out of this is that if we can cut off or wean off the inotropes earlier, then better it is for the patient. The role would definitely remain. That's what I make it.
Yeah, I think that the inotropic score is useful because you can have a nomenclature for this dose of inotropes. So I think that 20 inotropic units is the cutoff for starting the alarm, so ringing the bell of alarm. And if this dose is reached or cannot be reduced, then it's very important that you consistently consider escalation.
The final thing which I want to ask, and then I can we can go to the next presentation. So once you are planning to get the Impella down and keep it there for 2-3 days, if there is a clinical improvement, very good. If still the patient is not improving clinically, what are the indicators, parameters you are looking at how to wean off Impella? Are you keeping the PA catheter also there along with?
Yeah. So if the patient is not improving, you cannot remove the Impella.
So then you continue.
Of course, you have to continue the Impella because, I mean, if you remove the Impella, then it's about the danger shock data. 81% had the Impella removed, but only 56% survived. In our series, the same number of patients who had the Impella removed survived. So that means
I was asking a little different. I was asking the systolic pressures are still borderline, the urinary outputs are still borderline, but any other indicator you want to say that this indicator I'll keep checking that if that improves, then probably we are, you know, much ahead of the clinical improvement. Clinical improvement will follow, like PAPI, you know, the pulmonary artery pulsatility index or something.
No, I think that the most important parameter in clinical practice is capacity to administer ACE inhibitors or beta blockers. If you cannot give any prognostic therapy, that means that the patient will be on 100/0 blood pressure, then staying in the bed, not able to mobilize. You start with, again, inotropes in 6 hours. Then you discuss about sepsis, but it's just heart failure without no recovery. So the patient was not ready to remove the pump.
Okay. So I think it is an amazing discussion we were having. So, but for the sake of time, we have to stop here and go to the next friend. Dr. Federico, wonderful. It was absolutely amazing to have you with us today.
Thank you. Thank you very much. Bye-bye.
Thank you.
Thank you. Bye-bye.
So let's move to the next. I think Dr. Ratish has to leave and he wants to present his presentation. Dr. Ratish, can I invite you?
Thank you, sir. Thank you so much.
Yeah, Ratish, go ahead.
I think I need to share the screen. Can you see my screen, sir?
Your screen is visible, but not the presentation. Yeah. Just open your presentation.
I'm just opening it.
I think it's yeah.
for this opportunity. I'm just in a hurry, so I'll just briefly present it. So last 1 year, we had done about 7 cases, of which 6 were primary high-risk PCI, primarily high-risk PCI, protected PCI. And 1 was we did it during the procedure due to deterioration, and the outcome was not good in that case. But the other 6 cases, we had a wonderful outcome. And most of the cases were unprotected left main with triple vessel disease or last remaining conduit vessel, and with severe LV dysfunction, and most of them were surgically turned down patients. And so the results were good, except 1 case which already had a shock. And also we had treated some cases of acute myocarditis, and they had a good outcome, about 3-4 cases. And so to present this case, which we had done recently, the 52-year-old male smoker, COPD, he presented with an acute CVA and also found to have ACS at that time. He had probably an anterior MI with a LV clot, and he presented with a stroke, and he had cardiogenic shock, and he went into multi-organ failure, and he was admitted elsewhere. And over a period of 2 weeks, he gradually recovered to some extent, NYHA class 3. And then angio was done. Then it was showing a left main, critical left main disease with triple vessel disease, severe LV dysfunction with moderate to severe MR. And in view of the viability thing, we did that. He had a perfusion defect about 7%, which was matched perfusion defect, and rest of the myocardium was viable and high syntax score, and surgical referral was done. But in view of the comorbidities and severe LV dysfunction, it was turned around by the surgeons. So this was the angio. I will be showing it subsequently. So LAD was osteal CTO, and RCA was also osteoproximal CTO, and 2 LCX and RI, which was there. These 2 were the only viable vessels, and RI was giving collateral to the LAD. So based on the high-risk assessment, we had decided for the Impella PCI. So we planned, and this is the right side axis because that was straight and it was reasonably good. And USG guided and USG and fluoro guided axis was done from the right side. And initially we put the Impella, and unloading was done for about half an hour. And here we use the single axis because both the radials were not available for intervention. And so we had to use the right and left femorals. The right femoral was relatively straight, and it was a bigger caliber. So we used that for the Impella, and we used for the angioplasty also, we used that axis, single axis. And left CFA axis was used for basically doing the contralateral injections. So we use this, all the large bore axis, USG guided and USG and fluoro guided axis. So this was the angio of the left system. You can see there's a LAD. This is osteal cutoff. It's almost at a 90 degree, and we don't know where is the cap. It's ambiguous cap. And then there's a ramus, which is relatively big, and you can see it is filling by ipsilateral collateral the LAD. Ramus is also diseased. Left main is also diseased, and RC is also osteoproximal disease. So you have double CTO and with severe LV dysfunction. So there's no other option. So initial planning was to unload the LV and then attempt PCI to LAD and RCA CTO. So this is the axis and all. And so we attended the LAD PCI, use that super close 90 degree and try to cross the LAD with various hardwares by antigrade wire escalation. We tried for almost 1.5 hours. But unfortunately, despite repeated attempts, we could not enter the true lumen. And since the distal left main was tight and the LAD, the ramus ostium and even the LC is also diseased, so we didn't want to prolong the procedure. So we came out and we thought we'll first revasculate the right if possible. And then with the support, we can plan for the left. So right was relatively easy. Antigrade wire escalation, we could cross the lesion, and then we used the IVUS. We found the distal wire was in the true lumen, and then we dilated and extended the RCA. 3 stents were put. However, after putting the third stent, after doing post-dilatation, there was sudden no reflow and patient went into complete heart block and cardiogenic shock. And we could see clearly the decoupling, the ventricular arterial decoupling was seen for almost 15-20 minutes. It is a difficult situation at that time. In between, you can see that decoupling. So only Impella assisted during that time, 15-20 minutes. So there was hardly any output. So then immediately temporary pacemaker was placed and thrombosuction and apiximab intracoronary. And subsequently, some flow was established, almost immediate 2 flow was established. And left system, we checked for any deterioration because of intervention, but it was okay, except for some dissection of the LAD ostium, but that was fine. And so in view of the critical condition of the patient, we didn't want to intervene the left system at this point. So we came out and the left CFA axis was closed with ProgLide, and we put the Impella. And then next 2 days, we observed the patient, his condition gradually improved. There was no complication. Lactate also came down from 4.7 to 0.6. So then we thought, anyway, now only the left system, we wanted to check whether the right is still functioning, flowing well. And we wanted to do the left system, the RAMS and the LCX. So this time, right already Impella is there, so we didn't have an option. This time, there was a left side also high bifurcation. We already punctured the CFA. So this time we went from the SFA for the axis, and we did a check engine on the right side. It's showing a patent RCA. And this time we wanted to address the left system. So the plan was to keep it simple because we didn't want to do a complex bifurcation at this time, because LAD anyway, we can't address it. We just wanted to keep it simple. And since the RAMS was a relatively bigger vessel and it is supplying collateral LAD also, we thought we'll keep it as a main vessel and LCX as the branch. And we dilated both the vessels. And then the IVS run from the RAMS showed fibrocalcific disease with a diameter around 3.2. And the distal left main had severe calcific circumferential calcium with the proximal left main diameter almost 5. So this is the distal left main, and then coming proximally, we can see the left main is almost 5 millimeter. And LCS also revealed a fibrocalcific disease with a diameter of about 2.5. So in view of the severe calcium, the calcium modification was done with the Scoroflex followed by IVL balloon, both the RAMS and the LCX. And after this, we did stenting left main to RI with the 3x30 onyx we put. And this is after putting that, this is the IVS run. It showed a expanded stent without any complication. And then we crossed to LCX through the struts, and we took a pullback from LCX also. That was also showing okay. So aim was to just do a provisional this time because of the severe calcification of the distal left main, and LCX size was not very big. So we just wanted to do a provisional. So after doing post dilatation of the left main to RAMS stent, we recrossed to LCX, and we dilated and did a drug-eluting balloon followed by kissing balloon inflation with the RAMS and LCX. And then we did a final port. These are the final angles. And then within a few hours, the patient was hemodynamically stable. There was no requirement of inotropes. It was fine. So we just we removed the Impella the same day within a few hours. And exercise was closed with 1 ProgLide. So his condition gradually improved. He's now NVHA, almost NVHA 1 on GDMT, and his discharge EF improved from almost 20% to 35%, and it is on the road to recovery. So here we have a case of a double CTO and very high risk case with a severe LV dysfunction, distal left main, and with severe MR and surgically turned down. And we could do this just because of the help of Impella. And during the procedure, we had no reflow situation, almost half an hour. There was hardly any pulse, but he maintained, his sensorium is absolutely fine. He doesn't have any hypoxic ischemic injury. And so this shows importance that, this helped. And it also helped the patient to stabilize over the next 2 days due to initial deterioration. However, over subsequent days, 2 days, he improved. And single access technique definitely helps in this kind of cases where we have peripheral arterial disease. That's all I want to present. Thank you so much for the patient hearings.
Thanks, Satish. Thanks. It was really wonderfully done. Very complex case. And I think all things you have mostly covered. But tell me, once you had a no flow,
Yes.
what were the pressures? The
The
Impella flow I can see.
Yes. It was just very low. I mean, around 80, 90, that it was just almost 60. Sometimes, in fact, we had given immediate CPR also. Patient had arrested CPR, then subsequently, immediately, we put the temporary pacemaker, and he was given high-dose inotropes. So initially, it was a very difficult situation, but over a period of time, next 5 to 10 minutes, his condition gradually stabilized.
Okay, great.
And then we could gradually wean him off the inotropes also subsequently.
So any inputs from Rahul or Dr. Girish, anybody?
I think very well handled, very complex case. Only what is the situation of the MR now? Like any plan for the, is it
MR
improved?
It is improved now. So EF has improved to 35%, and MR also severity has improved to moderate only, moderate to severe, so moderate category. So aim is to just observe him for a few, maybe few weeks, and in case if required, we will see how we can do whether to go for some intervention or not.
Only thing is
But I think
there
we
was a
should
tight
optimal
critical OM lesion as well. Maybe
Yes.
that could have been handled because you were already handling the thing. That's the only thing.
Yes,
So whatever you could have revascularized, LED was tough, but I think very well managed case.
Thanks.
Right, Ritesh, I think you are in hurry, perhaps, but wonderfully. So listening to your case was really good, productive part of the symposium. And for the sake of time, let's move ahead. Anand called me in the morning that he will not be able to be here because his son is not doing well. So he just requested me because he had a presentation. So I'll just fill in the blank with Anand. And I just made a small presentation just now, a few hours back, where I'm just touching upon few cases which I have done in the last few months. So let me just look at this. Where is that? This one? Okay. Okay. So similarly, as we are showing some cases, these are 1 or 2 complex cases which I have done last few months. How can I enlarge this? Yeah. Okay. So this is a case number 1. This was a very complex and critical case.
We can't see the PPT. Sorry to disturb you. We can't see the presentation.
Okay. No, is it not visible?
No, we can just see the screen, but we can't see your PPT.
Okay. Is it visible now?
Yes.
Okay.
You can go to the PPT mode. Yeah.
No, now visible? How?
Yeah, it is visible. Yes.
Okay. So this was one such case, 62-year-old male patient, who had anterior wall MI somewhere else in Amritsar, and he was in cardiogenic shock as well as congestive heart failure. So angiography was done there, which definitely Some connection loss. Am I audible?
Sir, you are audible, but we can't see your PPT.
I think, I don't know what's happening. I'm sharing it again. Visible now? Excuse me. Is it visible now? I hope my presentation is loaded in the proper format and visible. I'm audible.
Yes,
Visible.
yes,
Yes,
it is.
yes, Dr. Nagesh. So, sir, I'm presenting a case where a patient had a high risk coronary artery disease. He had basically, it is falling into CHIP category, elderly gentleman. And we had to offer the revascularization. I will go through the presentation step by step. So 79-year gentleman who presented with basically silent infarct. He came in heart failure. The ejection fraction was 20 to 25%. Patient came for restless nights, not able to sleep, not eating with weight loss. Patient admitted under physician intensivist, and I got involved on day 2 of hospitalization. Once all the reports showed there was a silent infarct with EF down to 20-25%. Enzymes were raised. His creat was also high. The eGFR was around 25-30. So this was the situation when I came across with a past history of hypertension, diabetes. He suffered from one episode of IC bleed 3 years back, and he had to undergo surgery for that. So there is a traumatic experience for this patient from his comorbid conditions. So based on these things, the family was not willing for open heart surgery, and in fact the patient was also high risk to undergo any kind of open surgery at this stage. So in our assessment, the patient had a complex calcified triple vessel disease. Patient required revascularization for the LAD. LAD was, the plaque was started in the left main, which was heavily calcified. We can see a 360-degree calcium even in angiography with a 99% stenosis in the mid LAD with a TIMI 1 or 2 flow distally in the LAD. And the RCA was also calcified, and long multiple plaques were seen which were critical. LCX was non-dominant, was the plaques were non-critical. So in this case, patient suffered from a silent infarct. The family was asking, if we want to conserve, what exactly conservation means? What we are going to look for, because the first episode itself, there was no chest pain. Patient came directly in heart failure, and what we are going to watch for on follow-up. If the heart failure is going to be the event which is going to get the patient to hospital, then it is a very drastic way of monitoring the patient, and it is not going to be acceptable for them. So they wanted that we do whatever is necessary to reduce the risk and make sure the quality of life improves for this gentleman. He was 79, and CABG was not on cards from their side, and even we were skeptical about the outcomes, surgical outcomes at this age with multiple issues. So we decided to do a supported multivessel angioplasty. So when I discussed with the family. My objectives were clear. The procedure has to be safe for the patient. The revascularization has to be complete. I won't accept incomplete revascularization, because ultimately it is not going to give him long-term good outcomes if we fail to open some of the critically blocked vessels. And simultaneously, we have to think about kidneys also. Any vitiation or any effect on the kidneys, patient going in ATN, that is also going to be challenged. It is going to make the patient's recovery unpredictable and discharge from the hospital unpredictable. So these were the context and challenges that I had when I was seeing this patient in the hospital. So, of course, there were discussions between IABP versus Impella. I told them, if we want best in current era, this is what we can offer if we want to achieve a good revascularization and complete revascularization. So Impella was inserted, Impella Smart Assist CP, and the access was from the right femoral artery under sono guidance with percutaneous closure device in C2. And I went through the same single puncture technique, and through the Impella sheath only, I kept another 7F sheath inside, which accepted it safely. And I used that access to engage the left coronary as well as the right coronary vessels. So you can see the wire went in easily, but then it required aggressive predilatations. After predilation, the flow was good. There were distal plaques, and there were multiple small branches seen perfusing the intraventricular septum and the apical area. Some segments of the LV apex were non-viable, which was documented on MRI, but majority of the LED territory was viable. So it was going to be helpful for the patient if we did the angioplasty for the LED. So IVAS was done, which typically showed a diffuse fibrocalcific plaque. The calcium at some segments was 360 degree, 270 degree, and it was a high calcium score considering its width, the thickness of the plate, then the length of affected calcified segments, as well as the arc. All the three parameters were on the higher side. So when we are looking at such anatomy, it is really a challenging job to give a good expansion of the stent at the end. We need good vigorous preparation of these plaques so that the MLA achieved are adequate. They are more than 5.5 based on the IVAS findings, or as suggested for the left main and LED ostial segments. So to do this, Impella really helped us, because there were episodes where there were asystole episodes where Impella took over and maintained the perfusion. So ultimately, I had to use cutting balloon, rotablation, and orbital were on shelf. Laser was also on standby, but cutting balloon followed by NC balloon helped me here. It did a good job, and I could achieve a good expansion of the vessels. I checked using IVAS also. IVAS gave, sorry, I don't have the video here. It is not running in my presentation today. But IVAS showed good cuts. There were good reverberations. All the signs were there, which showed good lesion preparation before we proceeded with the stent deployment. So patient required one long stent in the LED, which was everolimus eluting stent, 2.75, 48 millimeter. So this is the result after the stent was deployed. Brisk TIMI3 flow was maintained. Then we looked at the branches. All the branches were flowing. There were no compromises in the flow of the branches. Unfortunately, I did not need anything. No intervention required for the side branches, despite of putting a stent in a diffuse plaque area. Then the proximal, the distal left main to proximal LED also was heavily calcified and critical area, which was prepared with cutting balloon. And then I used a latest generation EES 3.524, starting from the left main, crossing over across the circumflex ostium and going into the LED, overlapping with the previous stent. And the pot was done with 4.5 by 6 millimeter NC balloon, and the LED was post dilated using 2.75 15 NC and 3.5 15 millimeter NC balloons. This was the pot and the post dilatation results. So IVAS was done to check whether the result is optimal or no. We could get areas in the proximal LED of 10.8 millimeter square plus. The expansion of the stent was good in all the segments. The position was good, and there were no edge dissections seen anywhere, either in the proximal or the distal edges of the stent. So further optimization as suggested by the IVUS was achieved, and the report was done. So this was my final result in the LAD. It was a good result. So while doing all these things, multiple steps of imaging, preparation, stent optimization, I could do it while maintaining my cool, because there was something to support. And because of that, I did not have to bother about his hemodynamics. Patient remained comfortable all throughout. The urine output was almost 1 to 1.2 liters at the end of the procedure. So kidneys were also well perfused while I did this complex intervention to the left, followed by right. Right, we can see it is a diffuse, heavily calcified lesion starting from the proximal segment, extending into the distal up to the crux. So I had to prepare this while taking the cutting balloon down, even after NC balloon pre-dilatation. Twice or thrice, all the things came out. I had to re-engage the RCA, then rewire it, and then complete the job. So while doing this, patient remained stable because of the Impella support. This is not possible without a support. Whatever the support we need, it is necessary, because these things happen in a calcified anatomy, and we ultimately fail to achieve a complete revascularization. So this was the IVUS, which showed again heavily calcified lesion, and there were cuts seen because of the use of cutting balloon. So 2.75 Wolverine followed by 3 millimeter Appetta balloons were used to prepare the lesion. IVL was on standby, but then the lesion yielded adequately. There was a coverage of the RCA with the stent starting from the PLV, sorry, to the mid RCA, and then another stent in the proximal to mid overlapping with the distal one. So 3.5, 48 everolimus eluting stent was used. Post dilatation was done using 3.5 millimeter NC balloon. IVUS was repeated, which showed a good expansion, no edge dissections, and the areas were more than 5.5 millimeters square in almost all of the segments. So final check should show a good TB3 flow. All the branches were preserved. There were no perforations or any other complications visualized here. At the end of the procedure, we took 15 to 20 minutes to wean the patient off Impella. We could achieve that. There was a crossover happening between the inherent cardiac output versus the Impella supported. Once the crossover happened, we reduced the motor speed and took it off. So we could do it successfully on table. We closed the puncture on table. So I could complete this revascularization in an elderly high-risk patient with low EF with kidney issues. So in my opinion, we should not touch a chip case where there are diffuse calcified critical lesions are without using a support device. Impella is best choice amongst currently available devices. It is necessary that we give a complete revascularization to the patient, because see, the patient is trying to avoid a bypass surgery. Whether it is by choice or out of necessities, we have to give a result which is at least comparable in a short to mid term with the CABGs, or better than that, in fact. And we need to have a complete revascularization to have a good long-term outcome for a patient where there is no margin of safety, or we can't afford to have recurrent issues with such kind of patients. Impella support made the complex high-risk PCI predictable in my case scenario. The renal function remained stable. In fact, create improved gradually. The LV function, which was 20 to 25% pre-op, post-PCI, day 2, it recovered to 40 to 45%. This was done by another cardiologist. So I surprised, I repeated the echo, and in my assessment also, the EF was improved to 40, 45%. Thank you.
Excellent case, Dr. Nagesh, and a few points which I'd like to know. You routinely remove Impella in the lab itself, or you would like to keep it for a couple of days, especially in patients who have severe left ventricular dysfunction and are chip cases?
Sir, I prefer not to keep it for long, because in ICU, the monitoring, managing the access site becomes unpredictable. There are people who are efficient, but we cannot sit there round the clock with the patient, and it gives some kind of anxiety. So it is difficult for me to tolerate that. But then I assess the patient's presentation, whether the patient came with shock or no. This patient was not in shock, even if the EF was low, the lactates and everything were normal. That is one thing, whether the patient has hemodynamic instability warranting a support. If it is not there, then it is a purely protected PCI case. I'll prefer to remove on table, but then again, I will do that weaning gradually. I reduce the pump efficacy from P9 to P8, gradually look for the crossover happening. And then based on the response, I take the call. But my intention is always to remove it in the cases of protected PCI.
If I may ask a question, I mean, that was fantastic, Dr. Thakur. How long did it take you from the time patient was wheeled in to wheel out? How much time did the whole procedure take?
3 hours, sir.
3 hours.
In this patient, I remember 45 minutes to 1 hour was spent to take the access and to cross the aortic wall. Aortic wall was also calcified, even though there was no severe AS, no moderate AS. But it took almost 1 hour time for me to take the femoral artery puncture, put the impella, cross the aortic wall, put the impella, and then take puncture within the sheath so that I can insert another sheath to start the coronary valve.
To wean off and close everything, it was about 3 hours
Yes,
in and out?
Yes.
That's very, very competent. Great case. Thank you again.
Thank you.
Yeah, when you're doing such Impella cases, CHIP, with severe left ventricle dysfunction, do you consider putting a right heart catheter in most of these patients, or it is only meant for few patients? That is one part. And second is the Impella, which you use, was a smart Impella that didn't you monitor the left ventricle end-diastolic pressure as well in these patients?
Yes, sir. So you are right. In this case, I used now Smart Assist is only available. So it kept giving me LVEDP. So there was suction alarm. Everything was there monitoring wise. It gave me the pressure differences also. And of course, we need right heart catheterization also. This patient I don't remember, but I did not do it on table because it would have required another 15-20 minutes of efforts. So I was focused on coronary job by supporting. So in this particular patient, I did not do, but in patients where there are hemodynamic issues and shock, right heart catheter is routine in my practice. Even for patients where we are doing PAMI, patient is in shock, I put a right heart catheter, monitor PCWP as well as the PA pressure, as well as PAPI, PAPI, and based on that, we take the decisions to manage the patient further after the PAMI.
A wonderful case. Thank you.
Thank you, sir.
Hello, everyone. I'd just like to inform that Dr. Rajneesh sir had to leave from this session for a primary case. So, however, the case presentations we are done with for the day. I'd like Dr. Girish Navasundi sir, Bali sir, and Rahul Gupta sir, if you have any concluding remarks, it would be great.
Yeah, if I may speak, it's quite evident that these days the traditional way of managing cardiogenic shock just with pharmacotherapy is actually not adding significant value, and at times it's worsening the outcome of the patient. An intra-aortic balloon pump has a role, but which seems to be less and less significant as the time goes by. And upfront appreciation of need for axial pump support seems to be a significant benefit if instituted very early in the course. And you wait long enough to wean it off. Don't be in a rush to wean off in acute PAMI shock until patient tolerates some vasodilatory ACE inhibitor or ARB and other heart failure medications brought on board, and then you wean off, and that is the greatest guarantee that patient may not have refractory shock post weaning. That was my learning today, and thank you, Veiva, for this speech.
Thank you so much, Girish sir. Dr. H.K. Bali sir, Dr. Rahul Gupta sir, and Dr. Anand Rao sir, please, if you can also speak a few words.
I think there is a question from the audience. We can address that.
Yes. Yeah, so we do have a question here from Dhananjay. It is difficult to continue Impella in conscious patients for more than 48 hours in case of femoral access. Can we remove Impella if there is still some requirement of inotropes?
I think if you are put in an Impella, the cardiogenic shock, it would be a good idea to keep it for a few days, even if you have to sedate the patient until the shock is recovered. You don't want the person to go back into shock. So the weaning process should be slow. And in cardiogenic shock, undergoing intervention, it should be in the CCU, as very rightly pointed by Girish. So these days, we like to wait for some time before we remove the Impella. In chip CTO cases, cases where patient is not in shock, you've done a procedure, and at the end of the procedure, you find the hemodynamics are good, and you are progressively try to wean off the Impella, and you see the cardiac output is doing well, and the pressures are great. And then you can, in the lab, you can remove it. But I would say in cardiac shock, don't do it. Keep it for some time after the. And second point is very important, that we need to know the hemodynamics of these patients. Only Impella is part of the story. I think many people undergo the impression that Impella is doing the trick. Impella is only providing you the support that a complete revascularization is done. And as the last speaker very rightly pointed out, you would have to take about calcified lesion, you would have to take about long diffuse lesion, you would have to do a complex angioplasty, and all that is part of the, you do a good image-guided complete revascularization under Impella support. And that is what is going to give you a long-term good result. So don't hurry in removing the Impella. Take your time to do it. And your CCU should be trained. The nurses and technicians must be trained how to take care of it. And if there are, there are alarm coming up, or whatever the suction signal is coming up, one should know how to address it. So it is a long-term management of cardiogenic shock, and Impella is only Impella during the procedure is only part of that.
Thank you so much, sir, for addressing the question. I would like to ask Dr. Anand Rao, sir, also to have to give us a few concluding remarks. So I hope you're there. I think there is some network error, or if we do not have him. All right. I think we shall conclude the day today. Thank you to our moderator and our esteemed expert panelists and speakers. And a big thank you to all the participants for contributing to such an enlightening session. Your expertise and engagement have truly made this event very successful. We are sure today's discussion must have provided valuable insights on managing complex PCI with Impella. And dear audience, on the behalf of Veiva Scientific and Abiomed, we wish you all the best in your future endeavors. And we look forward to seeing all of you again in our upcoming sessions. Thank you so much. Thank you so much, everyone.